Every year, millions of people over 60 walk into hospitals trusting one simple idea. The surgeon said, I need it, so I need it. That trust feels natural, it feels safe, and in many cases, it's absolutely right. But not always. And the cases where it's wrong, those are the ones that haunt me. I spent years inside operating rooms, years watching what happens when the wrong procedure meets the wrong patient at the wrong time. I've seen a 74-year-old grandfather go in for a scheduled back operation on a Tuesday morning and spend the next 5 months learning how to stand up from a chair again. I've seen a woman in her late 60s survive a technically flawless abdominal surgery only to develop an infection that stole her ability to live independently, permanently. These aren't horror stories. They're Tuesday. They happen quietly in clean hospitals with skilled surgeons, and they happen far more often than anyone outside medicine wants to talk about. Today, I'm going to walk you through 5 specific surgeries that carry serious hidden dangers for anyone over 60. Not because surgery is bad, surgery is extraordinary, but because you deserve to know what the consent form doesn't spell out, and more importantly, you deserve to know what your other options might be. Stay with me through all 5, because at the end, I'm going to give you 4 specific questions that could genuinely protect you or someone you love from a surgical outcome nobody saw coming. Let me set the stage with something simple. Think about a rubber band. A new rubber band stretches, snaps back, handles the tension. Now think about a rubber band that's been sitting in a drawer for 20 years. You stretch it the same way, and it cracks. It doesn't bounce back, it breaks. That's not a perfect analogy for the human body, but it's closer than most people realize. A body at 70 or 75 doesn't respond to surgical trauma the way it did at 45. The heart pumps with less reserve. The kidneys filter medications more slowly. The immune system, which is your frontline defense against post-surgical infection, operates at a fraction of its younger capacity. And the brain, this is the part that shocks families, the brain can become disoriented after general anesthesia in ways that last not hours, not days, but weeks or even months. There's a clinical term for it: postoperative cognitive dysfunction. In patients over 70, it occurs at rates that would alarm you if they were printed on the surgical consent form, but they aren't. They almost never are. Now, I want to say something important before we go any further. Age by itself is not the enemy. I've seen people in their 80s recover from procedures faster than some people in their 50s. The real issue isn't the number on your birth certificate. It's something called frailty, a measurable medical condition where the body's reserves have dropped below a critical level. Nearly 40% of adults over 75 show clinical signs of frailty. Past 85, that number approaches 60%. So the question that actually matters isn't whether someone can survive the operation, it's whether they can survive what comes after: the recovery, the rehabilitation, the months of healing that a younger body handles almost automatically, but a frail body may not handle at all. That distinction is going to be critical for everything we're about to discuss. Let's start with the big one: coronary artery bypass grafting, what most people simply call open heart surgery. It's one of the most performed major operations on older adults worldwide. The logic behind it is straightforward. Your coronary arteries are blocked, blood can't reach your heart muscle properly, so we take a blood vessel from somewhere else in your body, usually your leg or chest wall, and we build a detour around the blockage. For the right patient, this procedure is nothing short of miraculous. But here's what rarely gets explained in full. To perform this surgery, the heart has to be stopped, completely stopped. A machine takes over the job of circulating your blood and oxygenating it while the surgeon works. That machine, called cardiopulmonary bypass, is effective, but it is not gentle. It triggers an inflammatory response throughout the entire body. Every organ takes a hit: the kidneys, the lungs, the brain, all at once. For a relatively healthy 62-year-old, the body absorbs that hit and bounces back. For a 79-year-old with compromised kidney function, early-stage cognitive decline, and controlled diabetes, that same hit can set off a cascade of complications that the surgical team may struggle to contain. Research published in major cardiology journals consistently shows that frail elderly patients undergoing open heart bypass face a 30 to 40% risk of serious complications: stroke, kidney failure requiring dialysis, prolonged time on a mechanical ventilator because the lungs can't recover fast enough. And in the highest risk group, somewhere between 10 and 15% of patients don't survive the first month. So what's the alternative? In many cases, there is one, and it's been transforming cardiac care for the past decade. Catheter-based interventions, procedures performed through a small tube inserted in the groin or wrist, can open blocked arteries or even replace damaged heart valves without ever stopping the heart or cutting open the chest. Recovery times are dramatically shorter. Complication rates are significantly lower in high-risk elderly patients. This doesn't mean bypass surgery is wrong. It means one question could change your entire trajectory. Is there a less invasive way to achieve the same result for someone with my specific health profile? That single question has saved more lives than most people will ever know. Surgery 2. If you're over 65 and you've never had back pain, you're in a very small minority. Degenerative spine disease is so common in older adults that some researchers argue it's not even a disease. It's simply what happens to a spine that's been holding a human being upright for 7 decades. And increasingly, the solution being offered is surgery, multi-level spinal fusion, hardware, metal rods and screws installed along the vertebrae to lock sections of the spine in place and eliminate the source of pain. For certain conditions, spinal surgery is genuinely urgent. A compressed spinal cord causing loss of bladder or bowel control, progressive paralysis. These situations demand intervention and there's no reasonable debate about it. But elective spinal fusion for chronic degenerative back pain in an elderly patient, this is where the evidence becomes deeply uncomfortable. Large-scale studies have shown that complex spinal fusion in patients over 65 carries complication rates exceeding 40%. 40%. And these aren't minor complications. We're talking about blood clots, surgical site infections, hardware that loosens or fails, and a particularly frustrating problem called adjacent segment degeneration. What happens is this: the fused section of the spine becomes rigid, which forces the vertebrae immediately above and below it to absorb all the movement and stress they were never designed to handle alone. Those segments break down faster, often creating new pain that's worse than what the surgery was meant to fix. And here's the part that should make every patient pause before signing. Multiple well-designed studies have compared aggressive spinal surgery against structured physical therapy, targeted steroid injections, and pain management programs in elderly patients with degenerative spine disease. The long-term pain relief, comparable, in many cases, statistically identical. But the risk profiles are worlds apart. I want you to hear that again. For many older patients with chronic back pain, the non-surgical approach produces the same level of relief without any of the surgical risk. Have you ever been told that surgery was your only option for back pain? If you have, you are not alone, and you deserve to hear this information before that conversation happened. Surgery 3. This is the most difficult one to discuss, and I understand why. When someone hears the word cancer, every instinct screams the same thing. Get it out, remove it, do whatever it takes. That reaction is completely human, completely understandable, and in many situations, completely correct. But 2 decades of watching surgical outcomes has taught me something that's hard to say out loud. Removing a tumor is not the same as saving a life. And sometimes, not always, but more often than the medical community has been willing to acknowledge, a massive operation in a frail elderly patient removes the cancer but destroys the patient. Consider one of the most complex procedures in surgery, a major pancreatic resection. The operation can take anywhere from 6 to 10 hours. It involves removing portions of multiple organs and completely rearranging the digestive anatomy. In a younger, otherwise healthy patient, this operation can add years of meaningful life. It can be genuinely curative. In an 80-year-old with existing heart disease, reduced kidney function, and clinical frailty, the operation may go perfectly from a technical standpoint. The tumor is completely removed. The margins are clean, and the patient still dies within weeks, not from cancer, but from a chain of post-surgical complications that the weakened body simply cannot fight off. Pneumonia, organ failure, overwhelming infection. There's a term for this in surgical literature: futile surgery. And a major study from one of the world's leading surgical colleges found that nearly 1 in 5 elderly cancer patients who underwent major tumor resections experienced what's called failure to rescue. A complication occurred, and the body didn't have enough reserve left to survive it. So what's the conversation that needs to happen? Before any major cancer operation in an older adult, there is one question that deserves a thorough, honest answer. If we don't operate, what do the non-surgical treatment options look like for someone with my age and my overall health? Radiation therapy has advanced enormously. Targeted drug therapies can shrink tumors and control disease progression with a fraction of the physical toll. Watchful monitoring in certain slow-growing cancers can preserve quality of life for years. That question, what if we don't operate, isn't giving up, it's opening a door to options that many patients are never told exist. Surgery 4. Hip and knee replacements are genuinely among the greatest achievements in modern surgery. That's not an exaggeration. For the right candidate, a new joint can transform someone from barely shuffling across a room to walking their dog, playing with grandchildren, returning to a life that pain had slowly taken away. It's remarkable medicine. But here's where the picture gets complicated for older adults carrying multiple health conditions. The key word is elective. This surgery is planned. There's no emergency. You have time to evaluate, time to prepare, and critically, time to ask whether this particular moment is the right moment for your particular body. Because the data is clear, in patients over 75 who also have three or more serious conditions, heart disease, diabetes, chronic kidney disease, obesity, lung problems, elective joint replacement carries substantially elevated risks. The biggest threat is blood clots. Deep vein thrombosis, clots that form in the legs during and after surgery, can break free and travel to the lungs. A pulmonary embolism in a healthy 55-year-old is dangerous. In a frail 78-year-old with compromised circulation and heart function, it can be fatal within hours. Layer on the risk of postoperative pneumonia from extended bed rest. Add hospital-acquired infections, which elderly immune systems are far less equipped to fight. Add the cardiovascular stress of the surgery itself on a heart that's already working near its maximum capacity. Now, I don't want anyone to walk away from this thinking they should never consider a joint replacement. That's not the message. The message is about timing and preparation, optimizing blood pressure, managing blood sugar levels, improving cardiovascular fitness, and building muscle strength before surgery can dramatically reduce complication rates in older patients. Some of the best hospitals in the world now require what's called a prehabilitation program before they'll schedule joint replacement for high-risk elderly patients. Weeks of structured exercise, nutritional optimization, and medical fine-tuning before the operation, all designed to give the body the best possible foundation for what it's about to go through. Has anyone ever mentioned prehabilitation to you before a planned surgery? Most people have never even heard the word, and it could be the difference between a successful recovery and a devastating complication. Surgery 5. I need to shift gears here because this last one is fundamentally different from the others. You don't schedule emergency surgery. You don't weigh the pros and cons over coffee with your family. A ruptured appendix, a perforated bowel, internal bleeding from an ulcer. These situations arrive without warning and demand immediate decisions. But here's exactly why this belongs on this list. Knowing these risks before the emergency happens changes everything about how families navigate those terrifying moments when they do arrive. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of medicine. In the most severe presentations, we're looking at 30 to 50%. That number isn't a reflection of surgical skill. It's a reflection of what happens when an already depleted body is hit with sudden catastrophic trauma and then immediately subjected to the additional trauma of a major operation. The kidneys, liver, heart, and lungs all come under assault simultaneously, and the body's inflammatory response, which in a younger person stays controlled and localized, can spiral in an older patient into something called a systemic inflammatory cascade. Organs begin failing in sequence. Each failing organ increases the burden on every other organ. It is exactly as serious as it sounds. So, what can you actually do with this information? Two things, and both of them are within your control right now. First, do not dismiss persistent abdominal symptoms. Pain that lingers, unusual bloating, significant changes in bowel habits. In anyone over 60, these deserve prompt medical attention. The overwhelming majority of surgical emergencies don't appear out of nowhere. They start as warning signs that get ignored, minimized, or postponed. Catching a problem when it's manageable means treating it before it becomes a crisis that requires the operating room at 2 in the morning. Second, and this one matters more than most people realize, have the conversation with your family now. Not in a hospital hallway at midnight under fluorescent lights while a surgeon waits for an answer. Now, while everyone is calm, while everyone can think clearly. What are your wishes if emergency surgery becomes the only option? What does quality of life mean to you? What outcomes are acceptable and which ones aren't? These conversations aren't morbid. They are among the most profoundly caring things you can do for the people who love you. We've covered 5 surgeries. Now let's make this knowledge useful, because information sitting in your head without a plan is just worry, and worry helps nobody. Before any major surgery, planned, recommended, or even just suggested, there are 4 questions every patient over 60 should be ready to ask. Write these down or screenshot this part of the video. Question 1. What happens if I choose not to have this surgery? A skilled, honest surgeon will give you a direct answer. If the truthful answer is that nothing critical changes in the next 6 to 12 months, then you have time. Time for a second opinion, time to strengthen your body, time to explore alternatives. Question 2, is there a less invasive option available? Medicine has transformed in the past 15 years. Robotic procedures, endoscopic techniques, catheter-based interventions, approaches that barely existed a decade ago are now standard in most major medical centers. The less invasive option isn't always the right one, but you cannot choose it if you don't know it exists. Question 3. What does recovery realistically look like for someone with my specific health profile? Not the textbook recovery, not the best case scenario. Your recovery based on your heart, your kidneys, your medications, your living situation. The answer you get should be detailed and specific. If it sounds generic, push for more. Question 4. What is your personal complication rate for this procedure in patients over 70? This is the question almost nobody asks, and it's the one that makes the biggest difference. Every surgeon tracks outcomes. They know their numbers. A surgeon who is confident in their work will share them openly. If that question creates discomfort in the room, that discomfort is telling you something important. Before we finish, I want to leave you with something that matters more than any of the statistics we've discussed today. I know someone, a 73-year-old retired school teacher, who was told by two separate specialists that she needed major spinal surgery for degenerative disc disease that had been causing her pain for nearly 4 years. She could barely walk to the end of her street. She'd stopped gardening, which had been her greatest joy for 30 years. She was ready to sign the consent form, but her daughter asked her to get one more opinion, just one more. The third specialist reviewed her imaging, assessed her overall health, and recommended a structured program, targeted physical therapy 3 times a week, a specific set of anti-inflammatory injections, and a carefully supervised walking program that started at 5 minutes a day. That was 3 years ago. Last spring, she sent her daughter a photograph from her backyard: 42 tomato plants, a small army of zucchini, roses along the fence that she'd planted on her hands and knees. She still has back pain. She'll tell you that honestly. But she has her garden. She has her mornings. She has a life she recognizes as her own. Here is the most important thing I will say in this entire video, and I need you to really hear it. A surgical recommendation is not a final verdict. It is the opening line of a conversation where you have every right to ask hard questions, demand clear answers, request every available alternative, and take whatever time you need to decide. Nobody in medicine holds more power over your outcome than you do. The surgeon holds the instruments. You hold the decision. And that decision, made with full information, with clear thinking, and without pressure, is the most powerful force in healthcare, more powerful than any technology, more powerful than any procedure. Let's bring everything together. 5 surgeries with serious hidden risks for people over 60. Open heart bypass in high-risk patients, where catheter-based alternatives are now available and often safer. Complex spinal fusion for chronic pain, where the evidence shows non-surgical approaches frequently achieve the same results without the danger. Major cancer resections in frail patients, where the goal must always be more good life, not just a successful operation. Elective joint replacement in medically complex patients, where timing and preparation can mean the difference between transformation and tragedy. And emergency abdominal surgery, where your best protection is paying attention to warning signs early and having honest conversations with your family before crisis arrives. None of this means avoid surgery. Surgery saves lives every single day, and it will continue to. The message is simpler and more empowering than that. Be the patient who asks questions. Be the patient who understands their options. Be the patient who walks into that consultation as a partner in the decision, not a passenger. Your age is not a liability. Your experience, your wisdom, your knowledge of your own body, those are assets that belong in every medical conversation you'll ever have. What question would you want to ask your surgeon before a major operation? Tell me in the comments. Every single one gets read, and if this video gave you or someone you care about even one piece of information they didn't have before, share it. Send it to your parents, send it to your siblings, send it to the friend who's been putting off that conversation with their doctor. That one share might matter more than you think. Take care of yourselves. Stay informed. Keep asking the hard questions. You deserve a medical team that welcomes every single one of them. And one final note, everything shared here is general health information drawn from published research and clinical evidence. Every person's medical situation is unique. Before making any decision about surgery or treatment, please have a thorough, honest, unhurried conversation with your own physician. They know your history, they know your body, and that conversation, informed, specific, and without rush-awe, is exactly where the best medical decisions begin.